It is critical to identify persons at highest risk of acquiring HIV infection in order to better target HIV prevention interventions. Epidemiologic studies and biologic evidence show that syphilis is associated with HIV risk. However, population-based estimates of the incidence of HIV following syphilis infections are lacking. We used population-level syphilis and HIV data among New York City men to quantify HIV incidence following primary or secondary syphilis diagnoses and to identify the highest risk subgroups for intensified prevention, such as HIV PrEP. Leading up to the time of our study and to date, syphilis cases among New York City men had been rapidly increasing, and men remained disproportionately affected by the HIV epidemic. For our study, we matched male syphilis cases reported to the citywide STD surveillance registry between 2000 and 2009 with data on HIV diagnoses reported to the HIV/AIDS registry. Then we measured annual HIV incidence following syphilis and identified risk factors for HIV infection. Our analytic cohort comprised 2,805 HIV-negative men with primary or secondary syphilis, 423 of whom acquired HIV, which represented 15% of the cohort. Overall, annual HIV incidence among men diagnosed with syphilis was 3.6%. Annual HIV incidence was high among men who have sex with men, or MSM, at 5.6%. In other words, 1 in 20 MSM was diagnosed with HIV within only a year after syphilis diagnosis. Annual HIV incidence was also high among men diagnosed with the secondary versus primary stage of syphilis and among men who were diagnosed with another bacterial STD after their reported syphilis infection. This latter finding points to ongoing sexual risk behaviors that are associated with higher HIV risk. Implications of our study are that since MSM who are not diagnosed with HIV may not seek care in primary care settings, it is important for healthcare providers to make use of different types of clinical encounters to discuss sexual practices and screen at all sites of sexual exposure. Given the resurgence of syphilis, providers need to be familiar with signs, symptoms, and stages of syphilis and local syphilis and HIV epidemiology. Upon diagnosing syphilis, providers can present population-based findings in as personal a manner as possible and use our data to underscore their messages. Screening is critical, and healthcare providers need to have ways to link patients with HIV risk, such as those with a history of syphilis, to HIV prevention services such as PrEP. Thank you, and a special thanks to my wonderful co-authors.